Bismillahirrahmanirrahim. We are delighted to start this session with Dr. Fahd Al-Qahtani, consultant structural and interventional cardiology. He will tell us about mitral edge-to-edge repair. Please proceed, Dr. Fahd.
Thank you, everyone. So my talk today is transcatheter edge-to-edge mitral valve repair using mitral clip. It's a practical approach. Usually this lecture proceeds with the imaging, then we proceed with just the clip. So the concept of the mitral clip is facilitate reconstruction of the insufficient mitral valve through tissue approximation. The main function is just to approximate the two leaflets. It's a mechanical solution to a mechanical problem. It creates a tissue bridge, as we see in the surgical procedure with the Alfieri stitch. This the concept is just came from Alfieri procedure. The mitral clip evolved over years, and the one we have now is called the Generation 4 system. It has the clip delivery system, and you have the steerable guide handle, and then you have the sleeve with the mitral clip implant. So we have the stabilizer that can be set outside the body, and with the 4G, the fourth generation, we have four kind of a clip. So we have the small and large clip, and we have two different design of the small. It's like one narrow and one wide, and the same thing for the large clip, narrow and wide. This is a 15 millimeter clip length, and this is 18 millimeter clip length. And also the coaptation length is 9 millimeter in the small clip and 12 millimeter in the large clip. But you have to notice that the clip arm length is 9, but the leaflet insertion to engage all friction element is only 6. So you need at least 6 millimeter to grasp with the NT, and 9 millimeter at least to grasp with the XT or XTW. So while we have all these four clips, so all clip selection is based on three main factors. The first one is the length of the leaflet, width of the jet, and the mitral valve area. For the leaflet insertion, if the length of the mobile leaflets in the grasping zone less than 9 millimeter, then we can use the small clip like narrow or wide. But if it is large, you have a large enough leaflets, you can use either the large, narrow, or wide. And based on the width of the jet, if you have broad jet, you can use NTW or XTW. It's like small or large with the wide space. So if the area of the valve is very small, you have only one option, which is NT, the narrow small. Otherwise, you can use other kind of clip. So before taking the patient to the hybrid room or the procedure room, so usually it's a patient selection by transesophageal echocardiogram, and you have all the criteria for coapt-like patient. And once you set the patient ready for clip, then this is important consideration before proceeding. So this can be done under general anesthesia or conscious sedation. It depends on the center experience. When we started our mitral clip program, we started with general anesthesia, and now we do it all with the conscious sedation with the TE probe, and usually the procedure takes less than half an hour. Patient will have a very large sheath in the femoral vein, will be heparinized to achieve ACT more than 250, and the TE probe in place for extended period of time. So be very careful when you take long time and the probe heat inside the body, and you have to change it or the imaging change. So you have to take this into consideration, especially with a longer procedure or you have a complication. So antibiotic therapy is all depends on the institution when to give antibiotics. So this is probably the most important step in the mitral clip is the transeptal puncture. The goal of this transeptal puncture is to achieve meticulous positioning of the transeptal catheter in the fossa of the left atrium. And the goal of this transeptal puncture is to cross the left atrium in a very specific point. Clip positioning, it should be perpendicular over the pathology with respect to the anterior, posterior, medial, lateral, and clip positioning at least 1 millimeter above the leaflet, so you can move the guide and the clip into the left atrium, and achieve this position with at least amount of device manipulation as possible. And you can see here all transeptal puncture for mitral clip should be done with the echo-guided TEE. So this is to observe tinting in the bicaval view in the mid fossa. You know that you are in the mid fossa. Observe tinting in the short axis at the base view, like posterior mid fossa, and observe tinting in the forechamber, and we take this for the mid to measure the height. Once you puncture, you have to look at the short axis and make sure you are not inside the aorta. And you can see the imaging here is like we are tinting in the mid fossa and mostly in the middle. So once you get the transcatheter tools all the way in the superior vena cava, then you can slowly pull back and retract from the superior vena cava to the mid fossa. Once you reach the mid fossa, then you can see the tinting and ask the structural cardiologist to make a tinting so you know exactly where you're located. Once you have the bicaval view, you can move to a short axis at the base or explain it, and then you see exactly that you are in the mid fossa and more posterior. So you move it from here all the way to the posterior. So your positioning will be appropriate in the mid fossa and posteriorly. After you achieve that tinting and you see it, then you can go to the 4-chamber or 5-chamber, and the main things for this is just to see what is the height from the annulus all the way all the way to the transeptal axis. So acceptable is usually more than 3.5. If you are like early in the experience, you will not accept unless you have 4 or 5 millimeters, so you have enough length to move the device. But if you have like very small patient and the only length you can get 3.5, this is very challenging, and usually we do it like we do it usually with the smaller clips. So once you have a good positioning, then you can proceed with the transeptal in the short axis at the base, and just make sure you're not touching the aorta. Once you cross, you place a guide wire all the way into the left upper pulmonary vein, and this is also guided by the echocardiogram. He will tell you that you are in the appendage or in the left pulmonary. So this is only just to move all your tools into the left atrium without making a problem or attachment with hitting the appendage. So, and you have to know, once your clip is into the left atrium, you have different maneuver. So you can move the device, and the echocardiographer can help also and ask the structural cardiologist to move based on this. For the guide handle, you can use the guide handle to go interior or posterior, this one. And the sleeve handle, you can go medial, lateral, or move the clip interior, posterior. So the stabilizer, this one, you can retract to go medial or advance to go lateral. So now we are in the left atrium, and we need a good positioning, and the goal of the positioning are positioning the clip centrally over the valve with respect to the anterior, posterior, medial, lateral, and align the clip so the delivery catheter shaft is perpendicular to the plane of the mitral valve, and positioning of the distal tip of the clip at least 1 centimeter above the leaflets. And also you can use the medial and lateral knob. This is the medial lateral knob to move the clip in the bicommissural view or in the bicom view, either medially, laterally, or interior, posterior. Also, you can use the cerebral guide catheter to go either posterior or go counterclockwise interior. And as I said before, you can use the stabilizer to pull, retract to go medial, or you can push forward and move the device laterally. Once you are like in the center of the jet, you can confirm that final mitral clip positioning is appropriate. You can use 3D, and you know that exactly is in the middle and separating the jet into 2 jets. And you can also go transgastric, and you see the orientation. This is the clip, and it's perpendicular to the coaptation line. And you can see here's the 3D images, and you can see the clip in the center between B2, A2, and is splitting the jet into 2 jets and ready just to dive and go deep. So once you confirm, test everything, then you can advance it into the left ventricle, advance the delivery catheter position clip approximately 2 centimeters below the valve, ensure the clip arm oriented perpendicular to the line of coaptation, and also you can use 3D to look at that and make sure you confirm good positioning when you advance it into the left atrium. And for successful grasping, you have to have optimal axis alignment. This should be done even before you dive deep into the LV. And you make sure the arm perpendicular to the line of coaptation. You can test at in different view, and you make sure that you are all aligned. And gripper fully raised, clip arm open to grasping, at least 120. And consider use of the X-plane to see if you are perpendicular, and use fluoroscopy to observe clip arm rotation when you're moving medial or lateral. And you can see here the clip is inside the left ventricle, and the 2 leaflets is just sitting on the clip and ready to be grasped. And the grasping technique is usually you don't use extensive force to grasp the leaflet. Retract the delivery catheter slowly back till both anterior and posterior leaflets sit on the clip. If the grasp appears satisfactory, just lower the gripper, and the gripper you can take it back and forth only to achieve a good grasping. And then you can close the clip arm angle to approximately 60, then assess the gradient, assess everything before a final closure. Then you go and make sure that you have a very good grasping. You see the length, how much you grasp from each leaflet, and also you do a 3D to make sure you have a good bridging, and you have also the double orifice in the transgastric view. And then finally release the clip and make sure before you retract everything that there is no pericardial effusion and everything is fine. And then finally you can close the hole that you made when you go with the large sheath, and you can use different technique. If you have a pair close, then you can close the vein with the pair close broglide, and if you don't have it, you can use figure of 8 suture, which is cheaper, easier. In summary, the mitral clip procedure is rapidly evolving and an important option among the current therapy for MR. Patient with moderate to severe MR and suitable anatomical characteristic must be properly defined to ensure optimal clinical outcome, and this is not TTE. Transesophageal play a crucial role in planning, patient selection, and intra-procedural guidance. Thank you. I don't think. No. في رضا بالعطاء وائل وهاني ها. ما في أحد؟ ما شفت أحد هنا موجود. Any question?
تختار بقى الا ربع. اتنين اعتذروا قبلي.
We are happy to have Dr. Hani Mahmoud with us. He will give us a talk about echo assessment of mitral regurg in the era of mitral tear. So, what echo is relevance in assessment for possibility of tear? And I don't know if you will talk us about the intra-procedural echo also.
I was planning to do this, but the topic was to evaluate how to evaluate the mitral regurgitation in the era of mitral clip. So they did not ask about the guidance. Actually, the guidance was covered in another session. Yeah, at least what I understood from the topic, that how to assess the mitral regurgitation for the sake of mitral clipping. Okay. Okay, I'm very sorry, first of all, to be late. I thought it is 3:45. So mitral valve, I came running actually, so I'm a bit listening. So mitral valve is not just about leaflets. Mitral valve is a complex. So from the annulus, leaflets, subvalvular apparatus, the chordae, even after the papillary muscles, the left ventricular wall segments carrying the papillary muscles are part of the mitral valve apparatus. And proper function of the mitral valve needs proper and harmonic function of each and every part of this apparatus, because if everything is normal, for example, and the LV is weak and dilated, the patient will have mitral regurgitation despite having healthy components of the mitral, the other components of the mitral valve. This is how the mitral valve looks like from a 3D aspect. This is the surgical view of the mitral valve, putting the aortic valve at 12 o'clock position, anterior leaflet, posterior leaflet. As you can see, this is the anterolateral commissure, posteromedial commissure. The scallops, this is P1 scallop, P2, P3, A1, A2, A3, and this is how it looks from the surgical view. This is what the surgeon sees when they open the left atrium. There are two categories of patients by which we can help with mitral clipping. So not every mechanism of mitral regurgitation can be treated by the mitral clip procedure or the mitral edge-to-edge repair. The first category is the degenerative mitral regurgitation, and we need to be careful when we say degenerative, because in the old days we used to say the word senile degenerative for the thickened calcific valves, right? But now the word degenerative in the era of mitral clip means flail or prolapse. So if you said degenerative mitral regurg, you mean here flail or prolapse, okay? So DMR, or the degenerative MR, is one of the categories by which the patients can be helped with mitral clipping, provided that the measurements of the feasibility is there. For example, in the long axis view, we freeze in systole, in transesophageal, of course, we measure this distance, which we call it the flail gap. So how much the two leaflets separated from each other. And from the short axis view, or by the 3D, we measure the flail width, the width of the flail segment compared to the annulus of the mitral valve. This is called the flail width. This distance, the flail gap, shouldn't exceed 1 centimeter, okay? And the flail width shouldn't exceed 14 millimeters. These measurements were taken from the Everest study, which was the first ever trial to be done on mitral clipping. So they chose very highly selected patients with very good anatomy for the mitral clipping. But with the increased experience of many centers now with mitral clipping, we are actually bypassing this criteria, the 14 millimeters. So we can go for bigger width than this, as long as the annulus is big enough to accommodate more than one mitral clip without creating mitral stenosis. Then the other category of patients, the functional mitral regurgitation, the FMR, okay? And this is very common. Patients like dilate cardiomyopathy, ischemic cardiomyopathy, the leaflets themselves are okay. However, there is tethering, especially in systole. And in that case, we freeze an insystolic frame and we measure the distance between the annular line, the imaginary line of the annulus, and the start of the coaptation. We call it coaptation depth. Again, that shouldn't be more than 1 centimeter. This is the classic teaching. But now, again, with the increased experience, we are overcoming this criteria. So 1 centimeter. And the actual coaptation between the two leaflets should be at least 2 millimeters, okay? What if there is some mild coaptation? Still, I can do mitral clipping if there is mild coaptation, but provided that there is no gap more than 5 millimeters. So if the gap is less than 5 millimeters, the clip will come in the middle, fill this gap, still you can grasp the leaflets. But very wide gaps, very big malcoaptation, very difficult for the clip to grasp because I need some distance in order to catch both leaflets. Germany, because they have the most experience with mitral clipping, they produced this very nice table many years ago, and it's still very valid, with the suitable, the best anatomy for mitral clipping, and this is the conditionally suitable anatomy for the mitral clipping and the contraindication. Although the contraindications are still contraindications, but some of these contraindications are being done now, actually. For example, if the patient has perforation, there is no rule for mitral clipping here. Mitral clip will not treat perforation. If the patient has mitral stenosis, if the gradient of the mitral valve is over 5 millimeters of mercury, because once you put a clip, they said even the smaller clip, if you put it, you will reduce the mitral valve area with 40%. So if you started with a stenotic valve, even mild stenosis, that patient will come out with severe mitral stenosis. Patients with rheumatic heart disease, because they have some element of stenosis because of the commissural fusion. Second thing, the leaflets themselves are not smooth. They are very rough with a lot of humps. If you approximated the leaflets together, they will not go up very well, okay? Because of the surface is not smooth, not healthy like the myxomatous or the functional MR. If the patient has a lot of calcification, especially in the grasping zone, for example, if I will put the clip in the middle of the mitral valve at A2B2, if A2B2 scallops are very calcific, again, that's a contraindication. But if the calcification is away from the grasping zones, fine, I can still do it. If the posterior leaflet is very short, if the posterior leaflet is less than 7 millimeters, that's a contraindication as well, okay? The cleft mitral valve, again, it's a contraindication. However, there are some sporadic cases done with mitral clip successfully. We have done one case in Aswan, but the patient was desperate, no other hope for him, and we did that with some technique like tilted clipping, and the patient was fine. But we are not advocating doing this for every patient. So if you are having a patient with mitral regurgitation and you are assessing him to see if feasible for mitral clip or not, we need to address these questions: mechanism, severity, and the feasibility of the repair. Carpentier classified the mitral regurgitation into 3 major causes or 3 major mechanisms. Type 1 mitral regurgitation, when the leaflets are moving normally. So he depends on the leaflet mobility to classify the mitral regurgitation mechanism. If the leaflets are moving normally, but the problem if the annulus is dilated or leaflet is perforated, that's type 1. Type 2, if the leaflet is hypermobile, mainly the flail or prolapse. Type 3, if there is restriction in the leaflet motion. If the restriction is only in systole, this is type 3B, dilated cardiomyopathy, ischemic cardiomyopathy. So the valve opens well, but closure is impaired because of the dilated weak LV. And type 3A, where the restriction is during systole and diastole. This is rheumatic heart disease mainly, okay? Like in this example, that's a long axis view. You can see a perforation of the anterior leaflet. That's a type 1, right? Here is the flail of the P2 scallop of the posterior leaflet. So this is type 2. This is one of the patients that can be treated with mitral clip. This is type 3A, where there is restriction in systole and diastole. Rheumatic heart disease, that's a contraindication for mitral clip. This patient cannot be helped with mitral clip. Type 3B, which again, the functional MR, this patient can be treated with mitral clip if the feasibility criteria are met, okay? Severity, exactly the same thing doing as we are doing in the transthoracic echo, but what is unique in terms of mitral clipping, the 3D vena contracta area. This is a full volume with 3D wood color to see the regurgitant jet. If you rotated this volume to look from the LV, you will see this view. This is the anterior leaflet, posterior leaflet, and this is the regurgitant orifice. In diastole, the flow is blue. In systole, you can see the regurgitant orifice. Looking at this orifice is very helpful because of 2 things. From this view, we can put that view in the MPR, multiplanary formatting, and we put our lines at the orifice of the mitral regurgitation jet, and we can measure the so-called vena contracta area, okay? So that's like the ARO, but this is anatomical regurgitant orifice area. From the parameters, the dimensions of this vena contracta area, we can anticipate this patient will need 1 clip or even more. Actually, that was my PhD thesis. Apart from the measurement, just looking at the orifice, this orifice here is right in the center, A2 and B2. That means grasping here will be at A2, B2, right? Because if I put the clip medial or lateral here, that patient will not get any benefit. So I have to put the clip exactly at the orifice. This patient has more or less medial jet, so grasping here will be more towards 3 and 3. This is another view for another patient with 2 jets, one medial jet small, but the major jet is a bit lateral. So grasping here should be lateral. That will help me to decide where to go by the clip. So not every patient will need a central clipping. Sometimes medial, sometimes lateral, sometimes more. Okay? The feasibility of repair, as we said in the previous table, but how to assess each scallop. So if you have a patient with TEE, now have a flail or prolapse. If you don't have a 3D or X-plane, you can use this protocol, the long axis sweep. I call it long axis sweep. This patient has a flail, but we need to identify which scallop is which one is flail. So start by the long axis view. Long axis view is cutting like this. Aortic valve, A2 and B2. So whenever you have a long axis view, full view for the aortic root like this, that means this is A2 and B2. And then just tilting the probe to the right of the patient, and then come back with the probe to the left of the patient, just tilting the probe itself from right and left. You are coming from the septum now. The first scallops you will see coming from the septum will be 3 and 3, and then if the aortic valve is fully open, this is 2 and 2. More lateral, you will see 1 and 1, and then the appendage at the end. So I'm cutting from here, coming from the septum. So 3, 3, 2, 2, 1, 1, and then the appendage. Just moving the probe from side to side, but start from the long axis view. Then you can decide which leaflet is which. Is it A2, B2, 1 and 1, or 3 and 3? Okay? If you have X-plane, it is much easier now because you start first with the commissural view coming from the appendage. This is P1, A2, P3, because you are cutting like this. And then you apply the X-plane. If you cut in the middle by the X-plane at A2, you will see A2 and B2. And then here, this is an example. I almost passed the time. This is a patient with flail. Here I'm cutting at P1, so I see A1 and P1. And you can do this with and without color. This is now a little bit medial. I'm coming from lateral to medial, so I started to cut at A2 and B2. This is at B3. So by this way, you are scanning the whole valve from side to side and to check whether this scallop is leaking or not, this scallop is flail or not, or collapsed or not, okay? If you have 3D, the story is much simpler because no need to imagine anything. This is direct vision for the whole valve, surgical view, aortic valve 12 o'clock position, anterior leaflet, posterior leaflet. You can see the flail scallop with the ruptured chordae, very well seen, 2 chordae are ruptured in this patient. Using this 3D volume, we can put that in the MPR, multiplannar reformatting, and you can do the same thing you did with the X-plane. You measure the annulus, and then you move your line from side to side, start with a commissural view here, and put your MPR line, and on the other side, you get a long axis view. And you can move from the lateral to medial like this, and take all the measurements for the assessment. Furthermore, there are a lot of softwares now to assess the mitral valve that give you a model for the mitral valve. This modeling automatically will give you all the annular dimensions, the scallops, and the malcoaptation gap very nicely with the tenting volume, with the prolapsed volume. Very helpful data for the mitral clip or even for surgical repair. That's another example of a patient with a very complex mitral valve anatomy. Anterior leaflet, posterior leaflet. You can see here there is a commissural scallop at the lateral commissure. There is nothing like it in the medial side. So this is A3, B3, 1 and 1, and this is a commissural scallop. That's a very difficult anatomy for the mitral clip. And unfortunately, 2D will not be helpful for you to imagine this anatomy. That's another patient. What is this? Don't look up. Everybody looked up, I know. So here is the cleft, okay? But between which scallop? The central scallops are A2, B2, and the medial scallops will be B3. So that's a cleft between B2 and B3. Again, that's a contraindication for mitral clip, except in some sporadic cases. What about this one? There is a perforation in the anterior leaflet. That's a contraindication for mitral clip. So in conclusion, this slide summarizes everything. if you are assessing a patient for mitral clipping, you need first to address the mechanism why this valve is leaking, because as we know, there are two mechanisms only that can be treated with mitral clipping: the flail prolapse, the degenerative MR, and the functional MR, provided that you meet the anatomical feasibility criteria for both categories. And thank you so much.